And it is a real privilege to welcome my friend and colleague, Tom Ingelsby, who's the director of the Johns Hopkins Center for Health Security at the Bloomberg School of Public Health. He's also a professor in the Department of Environmental Health and Engineering at Hopkins with a joint appointment in the Department of Medicine. Tom's work is internationally known in the fields of public health and public health preparedness and pandemic preparedness, work on emerging infectious disease and other biological threats. We're welcoming Tom back to Georgetown, where he was an undergraduate a few years ago, then went on to do his MD at Columbia in New York, and internal medicine and infectious disease fellowships at Hopkins. Tom is a busy guy. In addition to running the center, he's now on a temporary assignment at HHS, helping with the COVID response. As a country, we're lucky to have someone as talented as Tom helping out in this effort. So without further ado, Tom is going to speak to us today about the COVID pandemic and lessons learned for future pandemics. Tom?
Well, thanks so much, Richard. Let me just start by saying I have a very fond place in my heart for Georgetown. I loved being there as an undergrad. I have had many relatives, current generation there, in undergrad and grad, and I think it's an incredible place. And Richard is, I'm not sure if you recognize the incredible gift of Richard Waldhorn to your institution, but he's wonderful. So thank you for inviting me to this Grand Rounds. And so as Richard said, I'm going to talk about lessons from COVID-19. Obviously, there are lessons upon lessons upon lessons, so we can only focus on a few today. I'm not going to really focus on clinical lessons because I think you all probably have learned them or helped teach others those kinds of lessons already, but I'm going to focus more on public health and policy, and maybe hopefully we'll provoke a little bit of discussion at the end. So let me start with just a kind of a quick reminder about the origins of this pandemic and what we might do differently the next time we see the beginnings of a pandemic. So this is one of the early papers that was published. I suspect many of you all read this at the start. And it's just to say that even in early January, things could have been reported to the world more quickly, we now know, but we did know many things in January. We knew early in January that this is a novel coronavirus. We knew that cases were confirmed outside Wuhan, so beyond the original site of the outbreak, relatively early. You can see here, at least in this depiction, that it was somewhere in the second week of January. We could see what was going on within Wuhan around the start of the pandemic. We'll come back to kind of if you all want to, a discussion about the origins and the WHO commission that just completed its work or is completing its work. I won't focus on that at the moment, but a lot was known even in the early January. And we knew and we could see from reporting that was relatively open at the beginning and then became much more shut down as time moved on, that healthcare systems were being overwhelmed in Wuhan. Wuhan is a very important city in China, very developed, and people talk about it as the Chicago of China. And so it was clear that in the Chicago of China, that major healthcare systems were overwhelmed to the point where they were building new hospitals to take care of all of the sick. And so in the course of January, we saw the confirmation of human-to-human transmission. We could see many of the warning signs of a new pandemic, including healthcare worker infections. We could see that, sorry, just moving my cursor over here. We could see that hospitals, we just touched on hospitals and ICUs were becoming over capacity or overwhelmed. We began to see healthcare workers dying. Doctors and nurses were sent from other places in the country, and enormous efforts underway to try and control this virus. We also saw that countries were beginning to find travelers with this disease in many parts of the world. And so we knew early on in January, mid to late January, that a lot was happening. And yet the world, including the US, still had a hope that, and kind of an unreasonable hope, that things would be contained in China. It was a China problem. If you look at reporting in the United States in January and even in February, mid-February, it was kind of like an eerie calm. We reported on silly things and talked about the pandemic as a China matter, where, in hindsight, and for some kind of in present sight at the time, it was really clear that a pandemic was going to occur. All the things were in place for that to happen. And so we eventually got to a pandemic response, but really it wasn't until March that the US was fully engaged in a pandemic response. Hospitals, even in the beginning of March, hospitals were still calling the federal government wondering, do you think we're going to have a special role here? What is the approach? A lot of kind of slow off the start reactions across the country. And so what I think we need to think about and prepare for the future is that, political leaders, healthcare leaders, public health leaders need to make judgments earlier in this kind of national, international event. And what those things would include, this would not be a complete list, but we should be initiating a vaccine program, a therapeutics development program, clinical trials, the rest, right at the start. We ended up, having a vaccine program that has been extraordinary, but even moving that back a month or 6 weeks, we're losing billions and billions of dollars per day in this pandemic. So 6 weeks would make an enormous difference. So moving that process earlier, moving the transition to mass throughput diagnostic testing, that was a real fumble in the US. We moved very slowly, and we should be prepared in the future to engage industry right away in the testing in the mass testing program, and that didn't happen. Healthcare system preparation, scale up of PPE, other things that you all could see and feel in your own institution, as well as much more clear, honest communications from the federal government. And that was, perhaps a particular instance of, particular administration, but we need to have as our default assumptions that we are going to communicate very clearly and honestly right from the start. And then others, which we'll talk about. Okay, so first lesson, we need to move much more quickly when the signs are there for a pandemic to be moving around the world, and not wait until it is fully present and clear in the United States. Okay, the next thing to talk about, what have we been doing about coronaviruses in the last 20 years? Well, we know coronaviruses cause mild disease, and everyone at this point knows well that we have 4 endemic coronaviruses that affect humans, responsible for lots of the colds that we see. There's seasonality to it. There's asymptomatic spread, occasionally causing lethal disease, and we don't have lasting immunity. So we see these endemic diseases happening. Then we also have seen in the last 20 years 2 very serious, potentially pandemic coronaviruses that cause very serious human disease, SARS-CoV, and we all know the story of SARS. Many public health experts in the world believe we got quite lucky to have contained SARS in the way that it was contained. We also saw that it still presents a laboratory threat, or at least where it's being worked on, we saw multiple laboratory accidents. And then we had MERS-CoV, which also causes very serious human disease. And we all know it's the story there, very high case fatality rate. Fortunately, relatively few large outbreaks, but when they've occurred, they have been very dramatic and caused large numbers of illnesses and national level economic woes. So even though it's caused relatively few cases, tiny as compared to what we're living through now, it's still a serious disease. But despite having these 4 endemic coronaviruses and 2 potential pandemic coronaviruses, our overall collective effort around therapeutic and vaccine development for coronaviruses has been not where it should be. We'll say more about that in a minute. This is just an earlier tree showing kind of the connectedness of the coronavirus viruses that cause endemic disease and epidemic disease. Just mostly just for kind of like just a glimpse, an interesting glimpse. But more importantly, is this: why don't we have why haven't we had a major effort to develop vaccines and medicines for pandemic threats? Our system right now is designed well for endemic diseases. It's designed well for influenza medicine and vaccine development. And it is designed to respond to deliberate identified threats that we know about. But for the disease X that's coming, for the next threat, we haven't had a program in place to be able to anticipate, develop the platforms to focus on the appropriate viral families. And so we were lucky that an international organization by the name of CEPI has been responding to and kind of preparing for MERS-CoV vaccines. That's an international organization. It stands for the Coalition for Epidemic Preparedness Innovations, CEPI, and is well funded by foundations in the world. That has been an organization focused on unmet threats and developing platforms and infrastructure to go after those threats. They were spending a substantial amount of money on coronavirus vaccine development, and that helped kind of move things a bit forward when we got into SARS-CoV-2. But my view is that we should have a much larger program within government and other governments, not just the US bearing the burden of all of this, in the viral families that we care about the most. Even if it has not yet caused the pandemic we fear, do we have enough of a signal or a warning that we should be moving and investing in that? I think we should be doing that internationally. Okay, third topic here is just about the kind of planning efforts and the size of planning efforts that have gone on before for pandemics in the US. Around the time of bird flu back in basically in the 2005s and 6s, there was an effort that got really elevated within our federal agencies and to some extent in state health agencies, to some extent in academia. And at the time, this work was, this is one of the title of one of the documents that CDC prepared around this topic. And what they called back then non-pharmaceutical interventions is what we've been talking about during SARS-CoV-2 as either mitigation efforts or public health interventions or physical distancing. The terms are kind of all overlapping and they mean similar things. It's kind of the catch basin of the things that we do in the absence of vaccines or medicines to try and slow down the spread of an epidemic or a pandemic. And so there has been an effort in the US to focus on, to study non-pharmaceutical interventions or mitigation measures. And this is one chart in that document from 14 years ago, which shows the goals, which we now have all lived through, of those interventions. So basically the goals, as intended back then and still, are to lower the peak of the pandemic and to slow it down, to give institutions like hospitals a chance to prepare better for it. And so there was study of that. And here is another chart from that same report. At the time, there was an attempt to create something that looks like what we use for hurricane response. So kind of a category 1 through 5 pandemic rating. So if it's something that's pandemic, but quite mild in terms of case fatality rate or projected numbers of fatalities, then it might be a category 1 or 2. If it were something much more serious, it might be something in the realm of category 5. And you can see here, practically speaking, we don't use this category rating anymore because we learned in 2009 H1N1 that it is very hard at the start of a pandemic to understand what the case fatality rate is. You need a lot of information. You need to know denominators, numerators, and so it's pretty tough to do that. And so while the concept made sense to people in terms of really trying to get a sense of seriousness, that particular rating system is not used. But if you look at table 2 and you see the interventions that are listed, they're hard to see there, but they're voluntary isolation if you're sick, quarantine if you've been exposed, social distancing, community distancing, or community adult social distancing. Those are all things that are in what we're in the mix now and what we're trying to do or have tried to do over the last year. But even more interesting than that, if you look over to what they called then the pandemic severity index, you can see that they didn't even really get to purple, because purple seemed to be on the extreme side. And so there was a lot of focus on 1 and 2 and 3, but if you look down there at the case fatality rate, you can see that those are lower numbers. And just for a moment, just to talk about kind of a technical terms, case fatality rate, the way they've used it here and the way it is used, is to talk about the number of people who have observed illness or diagnosed illness, and of those people, how many die. It is not the same thing as the infected fatality rate, which is if we had much more perfect information through serology and understand and include all of the people who have been exposed, even if they were never tested, but got exposed and then seroconverted, then we know the infected fatality rate now, or we believe the infected fatality rate now for SARS-CoV-2 is something in the realm of perhaps 0.5%. In some countries, it seems like it's closer to 1%. It's obviously very, very dependent on age, so it's difficult to even summarize that. But this chart here is not about the IFR. It's about the CFR, the case fatality rate, the observed case fatality rate. And the case fatality rate in the US for much of this pandemic has been above 2%. So it's been in the purple zone, beyond which they were scarcely planning back, even in the CDC, which is the place where most planning was going on. So this is all to say, and this is one more chart from 10 years later that was talking about planning assumptions, again, CDC's experts thinking through this. And I'll just draw one go all the way down in terms of the rows to clinical severity, scale of 1 to 7. We don't really use that anymore, but it was an attempt to try and tabulate it. Case fatality ratio. And in column 7 is greater than 1%. So unmitigated, this virus, SARS-CoV-2, is greater than 2%, maybe 2.5%, I mean, not 2%, it's greater than 2%. And the other thing I wanted, so that's one thing. And then the second is the basic reproductive number. Look over in the middle of the chart. They have the highest rating there as 1.8, greater than or equal to 1.8. Well, we know that the reproductive number is actually, without interventions, without mitigation measures, is somewhere between 2 and 3. So again, just to say, all of this is to say, the past doesn't dictate the future. We need to be ready for other kinds of biological events, more serious events than have occurred before. A lot of the work that went into pandemic planning in the last 20 years in the US was oriented around influenza. Totally appropriate because it has caused the major pandemics of the last century, but we've had we've had scares with the coronavirus, we've seen other major outbreaks. We need to be prepared for broader scenarios than the ones that we've been thinking about before, both in terms of case fatality rate, in terms of the disease at hand, in terms of reproductive number of disease. And so we need to be careful about making assumptions about that lock us into particular scenarios. We see that the conditions around pandemics around the potential emergence of pandemics have been changing. And we listed a few here on this slide regarding ecosystems and travel and megacities, and those things have been emerging for some time. But the world we live in now is not the same world we lived in 100 years ago when we had pandemic flu in 1918. In addition, we see that biotechnology has been changing quite rapidly. And while it is an incredible force for good in the world, it also creates the potential for accident or for misuse. And so the threats we need to think about in the future aren't just the ones that we've, again, not the ones that we've seen, but it's possible it's ones that could be created inadvertently or potentially purposefully. And last thing to say on this is that our expectation should be that new biological events will occur. And they've been occurring at quite a frequency in the last 20 years. Nothing that looks like this, but we have seen event after event in the last 20 years in different parts of the world, that pathogens that had lethality rates as high as Ebola or transmissibility like 2009 H1N1. And it's when those two properties are together, transmissibility and lethality, that we end up in an event like SARS-CoV-2. Okay, so to another topic. This is a slide and a model that had major impact on White House decisions in middle of March. And what it shows is figures from an Imperial College study that that looked at the projected numbers of deaths in the US and the numbers of deaths in Great Britain if we did nothing to try to mitigate this disease versus what could be done if we put in place a series of interventions. This was obviously just a very early cut at that, and it was from a modeling team, but a very, very respected modeling team. And that, as alongside other analyses that the White House was reviewing, convinced the White House and ultimately state leaders from around the country to impose back in March a series of very serious mitigation interventions, either mandatory or strong guidance. And we know historically that this, going back 100 years, that we've seen these kinds of interventions succeed. We've seen, this is one of the well-known studies that was published by a very respected medical historian and social scientist, Dr. Markle and colleagues, and their conclusion from studying the history of these kinds of larger scale interventions was that cities that put these kinds of interventions in place early on and sustained them did much better over the long run. Not only did they reduce the illness and mortality, but other studies have shown that they have also had faster economic recovery. We also saw that, not shown here, but there were a number of studies early on in Hong Kong that showed these interventions were working in January and February for SARS-CoV-2, that when things were put in place, they could fairly quickly affect the epidemic curve. We also saw, this is from a study by colleagues of mine at the center and colleagues at Harvard, that looked at what was happening in Wuhan. And what you can see in the figure to the left is the rate of rise of critical cases in Wuhan and the numbers of deaths. And what you see on the left is, the left y-axis is the number of cases per 100,000, per 10,000 adults. And if you compare that to our national numbers of critical care beds, Wuhan itself was reaching a threshold of taking all ICU beds up in during the first couple of months of SARS-CoV-2. So that caused alarm around the world, although we didn't really have that. It was kind of clear intuitively, but the information was documented better a little bit later and not in real time. And what you can see is to the right figure, the figure on the right is the same calculations in Guangzhou in China, which is a city, comparable in population, 11 million versus 13 million, also a very developed city. And they put those measures in place early on and had a very dramatically different outcome as compared to Wuhan. And so we had kind of evidence from the city where it started and a comparison city in China. We also have seen many papers since then. I mean, this is not controversial at this point at all, but this is another example of the effective reproductive number that was being tracked over time in Wuhan. And you can see early on that the estimated reproductive number there without any kind of interventions was somewhere between 3 and 4, which is dramatic. That means every case was transmitting to an average of 3 to 4 others before interventions were put in place in Wuhan. And then we see that over time, relatively early in January, the interventions, many interventions were put in place, and they were able to drive the reproductive number down below 1, which is the goal, as far below 1 as possible to try and break the chain of transmission. And we know now that there are things that were done in China that the US would not choose to do or should choose to do. But what it does show in this study and in others, many others like this, was the impact of interventions and reduction of social interaction. The reason why I'm talking about this is that in the US, in the public health community, there was a lot of uncertainty about whether these kinds of non-pharmaceutical interventions, social distancing, physical distancing, would first of all be acceptable to the United States. Would people do them? Or whether they would do them in a way that was sufficiently rigorous that they would work. And so it was unknown. We had not done that before, and China had certainly never done anything like what it did in Wuhan. Other countries haven't done anything like this in modern times. So what we've learned is that they do work. They have extremely high downside consequence, but they do interrupt the spread of disease. And this is another example of what happened in Italy, kind of the second huge epicenter of disease outside of China and related adjacent countries. This was the epidemic curve of Italy in March, and you can see that nationwide stay-at-home orders were made on March 9th, and it took a couple of weeks for it to peak, but it was a steady diminution after that. I don't know, it sounds like I am hearing some feedback from another.
I got muted.
Okay, cool, got it, thanks. So anyway, so we have the curve. We have this is just one bit of extraordinary evidence now of these kinds of interventions. Another bit of evidence here was this map, and I'll show you a couple of subsequent maps that show the what was happening in March in terms of travel and movement of people. This was the last week of normal travel last year, where you can see yellow basically means, yellow and red means more travel. A light green means basically as, kind of normal as compared to historical patterns. And green and blue means much less than normal, or less and then much less of normal. This is the week before the president really declared that showed that chart from Imperial College, declared that the country will need to take extraordinary measures. And it was a relatively normal week, you can tell, for the most part. Scan ahead 10 days, 12 days, and you can see that in response to the announcement of this pandemic, there was dramatic reduction in travel around the country. Everything's much is moving green to blue. And then, scan one more week, and the country was really stopping. And what we saw ultimately in that period of time was that we did have a curve that went up and then eventually began to come down. It never came back down to baseline or close to it, but we saw the impact collectively of a massive reduction in social interaction and movement of people. Sorry, see, yeah, okay. This is a study that was done by a very respected modeling team at Columbia in New York, and their conclusions are that if we had moved more quickly to limit spread by putting interventions in place earlier, they say 1 week earlier, which is it's really hard to fathom. But their calculation was that we would have 30,000 less deaths in the US. I'm not a modeler, so it's hard to validate that, but they're making the case here, and I think it's worth considering. This is a preprint, but interventions made a huge difference, and to what extent we'll still be studying, and it depends on the context. This is just to say, kind of give a snapshot of where we are now in terms of the epidemic. Everyone sees these in various places in the Washington Post, New York Times, CDC, Hopkins, et cetera. And what you see is that in each of these cases, we took some attempts to try and improve social distancing, physical distancing after the various peaks in our experience. And then, it unfortunately kind of let off quickly in various parts of the country in June and July, and ended up with another summertime peak. We started to get better control of that. And then we entered the fall, where people were going back to school, back to work. And then we began to enter the holidays. We had many governors making different kinds of decisions. Some of them were beginning to relax measures in the fall. And of course, the holidays came, and we went into kind of an extraordinary peak, which is basically still, unfortunately, we lead the world in numbers of cases and in numbers of deaths. Partly that's because we are better at many places in the world at diagnosis, but even in absolute terms, we're still near the top of the list. And a lot of that has to do with what state leaders and what national leaders were telling people to do, and with willingness to make choices that reduced our social interaction. Next slide. So just as kind of a sum up of this, what I would say is this next particular lesson is that we have substantial evidence now that did not exist before this pandemic that physical distancing and masks, which we haven't talked about, have a huge impact. We also know that the costs are extraordinary, and that we over-restricted in places, both in the US and elsewhere in the world, where interventions didn't have a particular high ROI and had a lot of cost. So when people start talking about lockdowns, I think that term is the wrong term. We're not telling people that they need to be locked in their house, even when there's very, very high disease incidence. We're asking people to diminish social interaction to the point where we want social interaction to be for things that you need. We're not telling people they can't go outside, but we are telling people that restaurants are a place where there's documented substantial transmission. So kind of teasing out and making it more clear which organizations and settings and environments have the highest risk versus those that have relatively low risk, that's really important. We shouldn't be talking about yes or no, lockdown or nothing, which is how it was characterized by many, especially in the fall last year, where there were kind of accusations of this political leader wants to lock you down, this political leader will let you be free. That's the wrong way to talk about these things. The right way to talk about them is, what are the things that are most likely? Where do we have evidence that transmission is occurring? Can we limit those? And can we compensate people in society whose businesses have been shut down or badly affected through no fault of their own, but because those settings are high risk for transmission? We should be being much more smart about that. And we also need to be anticipating the kind of public reactions, anticipating people not being able to manage quarantines at home without support, the trouble that they're going to have with not being able to get out of work and having to pay bills. Those things need to be part of the social compact and part of our plan at the very beginning of the next pandemic. And finally, public masking. We talked about that and how crucial that is. The next thing I'd focus on is just kind of dialing kind of down into one of the more important details, which has caused terrible suffering and death in the country, is the impact of pandemics, respiratory pandemics. COVID is our clearest example, but we know it from influenza. We should have known it going into this, really, how difficult it is to both prevent introduction of disease into congregate settings, and then to contain it once it's in there. And so just as a snapshot, as of this week, we have seen SARS-CoV-2 documented in more than 31,000 long-term care facilities in the US. Huge number of people, both residents and employees, have been infected, and a huge percent of our population lost to this disease have come from people and employees in long-term care facilities. So we have to have plans that are better aimed at protecting those people. It is not, obviously, I think a lot has been tried. It's not for lack of effort, but we should anticipate that they will be disproportionately the victims again in future respiratory pandemics, and really prepare our congregate settings in ways that we weren't prepared to deal with in this pandemic. I was on a commission that looked at the impact of COVID in our criminal justice system, and it just ravaged many prisons, the people who are incarcerated in many of these facilities, and just learning about how people are moved around the criminal justice system, and how testing was so, in many places, haphazard, and screening was haphazard, and education of the people who worked there was not standardized in any way. And basically, what I learned in the process of being in that commission is that it's we have a federated system of governance in the country, and we also have a very, very federated system of criminal justice. And what you see in one criminal justice system may have nothing to do with what you see in the system that's in the neighboring state or even the neighboring county. So we need standards, we need expectations, we need data systems that can measure how what we're doing in these systems. These numbers are all collected by the New York Times. We don't have similar data streams within the government which can track this, and we need to do better. For the people who are incarcerated in our system, we have constitutionally a responsibility for their care when they're imprisoned, and we did not do what we needed to do. So we've talked about this, we need to do more. And the last bullet there, I certainly am in the camp that we need to protect people who are incarcerated with vaccine, and that they should be included in the group that are frontline workers, not because they're workers, but because they can't protect themselves. They're in conditions where they're confined. They can't be in, the ventilation is poor. The movement of people is beyond their control. They are confined in spaces. So I think we need to rethink that. And then a few thoughts on the distinctions between how the pandemic has been managed around the country. So if you look at this chart, which is from a few days ago, you can see the aggregate, which is that we are testing somewhere in the order of, testing unfortunately has gone down in recent weeks, which it shouldn't be. We need testing to be able to understand the shape of the pandemic and where to intervene. But in any event, we can see the aggregate numbers. The good news is that even with reduction in testing, we know that things are improving because the positivity rate has also come down substantially from earlier in January, and that's really good news. But if you break it down from that macro look at the federal level to the individual state level, you can see that really it's 50 different pandemics occurring in every state. It's some of them are obviously very similar to each other, but you really need to understand with much more precision what's happening at the state level. And if you look at that, you can see that many states, as of this week, was not the case back in January, but as of this week, many states are below 5% in terms of their positivity rate, which is a good thing. That's the WHO target. That's what CDC's target. But many states aren't. And we need to understand at the federal government level, people need to understand what would be useful to help those states in trying to drive their numbers down. But within the states as well, people should know. People should have that information. And while this information was made available to people from the beginning after the site was created, the federal government had a lot of information about states, about state numbers, about hotspots, about hospitals, that it kept both to itself and to governors' offices. And, in my view, the information should be out there because this isn't a kind of emergency that requires individual and collective behavior. And so every bit of information that it would affect the way people think about their own actions and decisions should be available to them. So we are now seeing those weekly reports that were written, and I think well done in the last administration by the data team in HHS and the White House. That was a part of the response that I really respected, but it never got out. And the new administration, fortunately, has now taken that kind of with some updates, adjustments, but now it's putting that online publicly each week for every state, which is really very, very welcome. Another chart here, also just to kind of like bring home the point about the importance of local conditions. You can see that this is the Hotspot Map back in December of 2020. One thing to note, just back, this is only 3 months ago, you can look at the colors against the key, and in many places in the country, the rate of disease was more than 250 cases per 100,000 per day, which is more than basically any other country in the world. So we had counties in the US, many counties and many states where the incidence of disease was, if that county were a country, it would be the #1 country in the world in terms of worst incidence. Or if that state were a country, it would place in the top 5 countries in the world for worst incidence. And so it shows how important it is to really understand local data to, first of all, again, for people to know where the pandemic is in their own communities and make their own good choices, but also to be able to direct more resources to inform governors. And now we see, 3.5 months later, the map, same map, just different background, same key, is very different. It's, some of the places that were worst hit have now, much better place. In some places which were better, moved in the wrong direction. But generally, things are moving in the right direction across the country in about 80% of states at this point, and the country as a whole is moving. But it shows, again, if you have a federal policy that's not very tightly connected to local conditions, that federal policy is going to miss where things are getting worse and things are getting better. And because of our federated system, we're going to have to live with this balance of federal and state and local decision making in future pandemics. We had a really interesting discussion at the center with colleagues from India about 2 weeks ago, and they were experiencing lots of trouble in their pandemic early on because of the distinctions between local choices and national choices. So they had a state system as well, and local leaders were making very different decisions as compared to national leaders. That was going so badly that they decided to pull up those decisions to the national level and really make it a national recommendations, national actions, really much more tightly controlled at the national level. And that worked for them. It made things better. They think it's really what helped them kind of get to the next phase in their pandemic. It's worth having that debate, not at the moment. It's worth having the debate as we go forward, like what is in the category of things that should be more nationally oriented versus locally oriented. But in any event, we're going to need to get better at being on the same page from national leaders and state leaders. And the political divisions in the country really were extraordinary and so unnecessary. And hopefully in the future, we learn from that. And so just to summarize some of those points there, very different experiences across the country, local decisions, local actions made a huge difference. And federalism is going to be part of our challenge in responding to any kind of nationwide crisis going forward. And finally, I think this is maybe my last slide here, science. Science wins. For all the things that we didn't maybe do what we wanted to do, didn't go as planned, or we didn't anticipate, science has been amazing in this pandemic in the US and around the world. If you think about the categories of things that we've learned and how fast that information has moved around the world, whether it's epidemiology, genomics, whether it's social science, aerosol science, the list goes on. Certainly clinical outcomes, clinical trials, it goes on and on. And so it's on the one hand, it's been disheartening in the last year to watch how, in some ways, science has been undermined in the U.S. by, not by, certainly not by the majority of the country, but by some. On the other hand, even in those conditions, science has delivered so much, and we could not, hope to be anywhere near where we are if we didn't have the vigorous scientific enterprise in the United States that's across the country, both in government, in industry, and certainly in universities and academia. So I think it's just good to reflect on a moment and think about the work that many of you all are doing, I'm sure, on the clinical side or the basic science side, translational side, to contribute to this. But without it, I think we would still, we would have suffered much more and not be in a place where we're hopefully now moving, hopefully, in the right direction. So just wanted to thank my amazing colleagues at our center. It's a super group of people.